Today, 19th December 2025, from 12 p.m. onwards. A very good afternoon to one and all. A warm and professional welcome to all of you to today's POPMA Study Club session. It is truly heartening to see such enthusiastic participation in our regular academic series, which has steadily evolved into a meaningful platform for learning, discussion, and professional bonding among practicing oral pathologists and microbiologists across the country. I, Dr. Bhuvan Nagpal, the host for today. I am the president of Practicing Oral Pathologists and Microbiologists Association. The core vision of POPMA has been very clear to strengthen practice oriented oral pathology through scientific dialogue, clinico-pathological correlation, ethical diagnosis, and evidence based decision making. The study club is an extension of that vision where we move beyond textbooks and focus on real world diagnostic challenges that each of us encounters under the microscope and in clinical communication. Today's topic, diagnostic pathways, clinico-pathological cases in oral pathology practice, is extremely relevant. In daily practice, accurate diagnosis is not merely about recognizing histological patterns. It is about integrating clinical history, radiology, gross findings, microscopic features, and sound reasoning to arrive at a diagnosis that directly impacts patient care, medical legal safety, and professional credibility. Sessions like these help refine that diagnostic thought process, especially for young practitioners and postgraduate students. We are fortunate to have with us a distinguished academician and clinician who brings vast experience in oral pathology teaching and diagnostic services, Dr. Kiran Jadhav sir. I am confident that today's session will be rich in practical insights and structured diagnostic approaches that can be immediately applied in routine practice. Before we proceed further, I would like to formally invite our learned moderator for today's session, Dr. Swapnita Patil Madam. She is executive member of POPMA and she is currently working as consultant oral pathologist at KIMS UAIMS Hospital, Sangli, to kindly take over the proceedings and introduce our esteemed guest speaker to the audience. Thank you once again to all the participants for joining us. Over to you, Dr. Swapnita.
Yeah. Good afternoon to one and all. Sir, am I audible?
Yes, you are audible.
Yeah. Today it's my privilege to introduce Dr. Kiran Jadhav sir, as he is one of my teachers, and I welcome him to our session. He has completed his BDS from KLE Institute of Dental Sciences, Belgium in the year 2004. He has completed his MDS from Bapuji Dental College and Hospital, Davangere in the year 2010. He has completed his PhD from KM Shah Dental College and Hospital, Vadodara in the year 2022. He is presently working as professor at Department of Oral Pathology and Microbiology, Vasantdada Patil Dental College, Sangli. He is running Kanak Diagnostic Center for Oral and Maxillofacial Pathologies at Sangli since 2019. He has about 28 national and international scientific publications. He has been invited as guest speaker at several scientific platforms. He is reviewer to several journals since 2022 as associate editor for Journal of Medical Case Reports published by Springer Nature. He has received Best Paper Presentation at National IOMP Conference and SALSI International Conference. He has completed 4 ICMR short-term students research projects. He has published a patent at Intellectual Property Rights, Government of India. It is based on concept of how microRNA can be used for assessment of lymph node metastasis in patients with oral cancer. So a warm welcome to Dr. Kiran Zada sir for as today's guest speaker for POPMA Study Club regular series. Over to you, sir.
Yeah, thank you, Dr. Swapnita, and thank you, Bhuvan sir, So I'll start sharing my screen.
Yes, sir. Please.
So just a minute. Just give me a minute. Is my screen visible?
Yes, sir.
Okay.
So just a minute. It's
Yeah,
not displayed.
it is getting displayed, sir.
Yeah. Is the PowerPoint visible now?
Yes, sir.
Yes.
You can put it full screen, sir.
Ah, yes.
So you can put it on hide. This app Zoom is sharing your screen. You can
Okay.
hide this one. Yes,
Yes.
sir. Yeah, over to you, sir.
Is it fine now?
Yes, sir.
Okay. So, good morning, all, and thank you, Dr. Swapnita, Dr. Bhuvan, sir, for giving me this opportunity to share our cases in the practice of oral pathology. So, before actually starting with the case presentation or actual cases, I would like to quote here the statement by our beloved Madam Dr. Anita Borges, Madam. She always used to say this statement during any slide seminar, and she always used to say that we as a pathologist should not run behind the diagnosis, and rather we should always try to identify the structures, cells, and try to correlate with the clinical, radiological, and other investigations, and then the diagnosis will automatically reach to you. So this was the statement which I heard it first time during my PG time in 2007 in VS Dental College, Bangalore, where there was a slide seminar and Madam was a guest speaker. So since that time, this statement is like imprinted in our mind, and we always follow whenever there is any case of for the diagnosis. So this statement stands true uh, in our oral pathology practice. So this was the statement I just wanted to share with everyone. So let us start with the cases. So the first case is a 40-year-old female patient uh, complaining about the swelling uh, in the right lower jaw region since 3 to 4 months, and she gave the history of there is a extraction of first molar tooth, that is 4-6 tooth, 6 to 7 years back, and on examination, this picture was shared by the clinician. On examination, what we can notice here is there is a very diffuse swelling in the vestibular region, obliterating the buccal vestibule and having diffuse borders as well. And this was exactly in middle of the these two teeth, that is 4-5 and 4-7. Also, if we see here, we can see that the 4-7 tooth is carious tooth, and the 4-5 tooth is also inclined towards the swelling. So this was a sort of a clinical picture what we had, and then when we received the grossing, when we received the uh, X-ray picture. So what we saw here is there is a intraosseous lytic lesion, osteolytic lesion, having a well-defined border surrounded by, and also we can see here 4-7 tooth, which is a grossly carious tooth, and 4-5 tooth is slightly inclined towards the interdental space. So this is the radiological features. Then when we saw the tissue, or when we saw the specimen, it was like a small ball-like tissue, or like what we can say a table tennis sort of a ball. So, and when we saw, or when we try to bisect the tissue, so there is one small video I would like to just share it. So here, when we tried to bisect the lesion, uh, after opening the specimen, what we could notice is, so see here, like so we all can make out here that there is some yellowish, shiny content, and this probably indicate that there is something like a deposition of the cholesterol deposits, and the gray dark content indicates the inflammatory exudate. And this was a sort of a lumen which was completely filled with this sort of material, and it was bordered by very thin sort of a wall, very thin sort of a wall. So then we processed this tissue and prepared the slide. And then when we saw the histopathological picture, so it was showing that there is very thin wall of the lining, and this was lining the cystic lumen. And the cystic lumen, this is a cystic lumen, was filled with amorphous eosinophilic material, and we can see there are large spaces, or some spaces are like clefts, so that indicates that there is a cholesterol clefts. So then when we focused the slide for higher magnification for the epithelium, then what we saw is, like, the epithelium was very thin, almost just 1 or 2 layer thickness of cuboidal to flat cells, and it was supported by a thick collagen fibrous wall. And then in the lumen part, what we saw is it was totally filled with the histiocytes, having granules, and there are a lot many inflammatory cells were also present, as well as the extravasated RBCs and all were present. So what we can think of here is like uh, the cystic lumen was filled with the inflammatory exudate, and because of that it has compressed the epithelium lining, and so the epithelium lining appears to be very thin here. So, considering the clinical feature, as well as the radiological feature and the histological features, what we can think of, like, it may be a case of a residual cyst, because there is a history of extraction of one tooth. So it might be like that tooth which was extracted having some periapical lesion which was left over there, and then it has just grown, and ultimately it has come to the exterior and then got infected. So it could be a residual cyst, or it can be a radicular cyst also, because there was one tooth, adjacent tooth, that is 4-7 tooth, was grossly carious. But one thing we should notice there, that there is no periapical pathology related to that tooth. Then it can be like a lateral periodontal cyst, because another adjacent tooth, that is second premolar 4-5 tooth, was having inclination towards the cystic lesion. So these are all the differential diagnosis in point of view the clinical and the radiological features. But then when we compare the histological picture, then the picture is moreover clear. That is, like if we see especially the radicular cyst or lateral periodontal cyst, like radicular cyst, wherein we see the epithelial cell proliferation, and we see moreover like arcading pattern, and also epithelium is thicker here, and it is having proliferation towards the cystic wall. Whereas in case of lateral periodontal cyst, the epithelium is also having proliferation. Usually, we see the plaques of epithelium, and it is usually in the form of a swirling pattern. But these sorts of features were not present in our case. Rather, the lining was very thin and having compressed against the cystic wall, what we can say. So all these features and the clinical point of view, what we can think of, so this may be the case of the residual cyst. So we gave the final diagnosis as residual cyst. So residual cyst is actually an inflammatory cystic lesion which arises from the remnants of the radicular cyst lining after the tooth extraction. So in our case also there was a history of extraction of the tooth, and it is usually a painless unless it is infected. So in our case we saw that the swelling was like communicated to the oral cavity, so that might be the reason it got infected and painful. And there is jaw swelling, that is augmentation of the vestibule we saw. And then radiologically we saw there is osteolytic lesion, bone destruction with well-defined irregular lesion. So clinical radiological features were correlating with the histological picture. Uh, some we should always be having the histopathological view on such cystic lesion, because it has been reported that especially the residual cyst has more tendency to transform into a primary intraosseous squamous cell carcinoma, which is having some devastating consequences to the patient. This was the first case which was correlating with the clinical as well as radiological as well as the histological finding. Now, moving on to the case number two. So, this is a 30-year-old male patient complaining of slowly expanding swelling in the lower jaw since 5 to 6 years. So, here we can see there is a diffuse swelling with a ill-defined border, and this is present here in anterior mandibular area. And there is if you see the surface area or surface skin, it is absolutely normal, and there is no sinus or no discharge from this swelling. And the swelling on palpation was firm sort of a swelling. So when we saw the radiographical picture of that swelling at different planes, then we noticed that again it was an osteolytic sort of a lesion inside the jaw, and it was like almost perforating the base of the mandible, and it is also having some scalloped sort of a border. Then the 3D picture was showing clear-cut idea of where the lesion was progressing. So if we notice here that the buccal side of the area where the lesion was present is absolutely intact. So it means that the lesion was progressing towards the lingual side. So if you see here, the lingual cortical plate was perforated, and also it has extended beyond the base of the mandible. So the lesion was moreover extending towards the lingual cortical plate, and it was taking the least resistant path, what we can say. So usually the inflammatory lesion which is progressing and causing the bone destruction, they cause moreover to the least resistant pathways. So the radiographical diagnosis which was given by radiologists, that is they were thinking of some odontogenic tumor, or it may be like some keratocystic lesion, or unicystic ameloblastoma, or they also thought of like a giant cell lesion. And since the lesion was very much closely approximating to the submandibular salivary gland, so they thought of it could be a salivary gland tumor. So these are the radiographical diagnosis. Then we received the tissue specimen, and the surgeon had removed the lesion as well as the part of the submandibular gland. So, in the gross picture, we can notice here this is a submandibular gland, and this dark black structure that we can see is the lesional tissue. So when we processed this tissue and again prepared the slide, and then we saw uh, the slide under first low magnification. So it was like showing that completely having filled with or densely populated with dark hyperchromatic cells, very dark hyperchromatic cells. And also, if you see here, there is a immature bone formation, that is osteoid areas of osteoid bone formation, and a few areas were showing some inflammation related to the extravasation of RBCs and all. And then when we focused it under more higher magnification, the picture was a little bit clear for us that it was showing the giant cells, and like they were having around 20 to 25 number of nuclei, and along with that the stroma was filled with mononuclear cells, and there were a lot of spindle shaped cells, and also there is a lot of kind of small blood capillaries also. So the histological picture uh, was moreover moving towards the diagnosis of a giant cell lesion. So we could thought of like it could be a central giant cell tumor, or the central giant cell granuloma, or another possibility may be an aneurysmal bone cyst. Then we searched the literature to reach to the like conclusive diagnosis. So what literature state that the histological point of view, the difference between especially the giant cell tumor and the central giant cell granuloma, that usually the giant cell tumor has large number of giant cells having more than 40 to 60 nuclei. So the giant cells are bizarre sort of giant cells, and there is a lot of mitotic figures as well we can see. But in case of central giant cell granuloma, it's a reactive lesion. So moreover, we see an inflammation, a lot of like mononuclear cells and all histiocytes, or what we can say, blood capillaries, extravasation of RBCs, and all those things, along with the giant cells. Whereas in case of aneurysmal bone cyst, it was clear that having some cavernous or sinusoidal blood filled spaces without lining of the endothelial lining. So the picture, what we saw is, of course, the presence of giant cells, but number of nuclei were less, and there were a lot of mononuclear cells were also present. Hemorrhagic areas and all were present. So, moreover, the diagnosis was moving towards the central giant cell granuloma. So, we gave it as a central giant cell granuloma with the aggressive variant. The aggressive statement was to just to correlate the clinical feature, like the lesion was progressing and it has crossed the base of the mandible also, it has perforated the lingual cortical plate also. Now, moving to the case number 3, this is also very interesting case, and this is the only picture what we have for this case. And the patient was a 17-year female patient having swelling and pain since 1 month. And what information received from the clinician is there is a missing 4-8 tooth, and this is the IOPA. Uh, what we received from the clinician, it shows that there is a well-defined radiolucent lesion, and it is measuring around 1 into 1 centimeter adjacent to this 4-7 tooth, and this is having some angular septage also, what we can notice in this picture. So this was the radiographical feature, and we did not receive any clinical picture per se. Then we received the soft tissue, and when we saw it, it was like a very soft sort of a gelatinous material, and it was white in color, measuring around again zero point 0.6 to zero point 0.7 centimeter. And most important was it was very soft. We first thought that whether it has been fixed properly or not, but then the formalin was present, so we just went ahead with the regular processing and prepared the slides and saw. So the slides were histologically at low magnification. There were two tissue bits, what we could notice here also. So the first tissue bit, that is showing the loose, sparse, pale eosinophilic stroma, and there are dark hyperchromatic cells here we can see. And then another tissue bit is showing a very thin lining, one or two just thin lining, and underlying area is like a loose areolar tissue. So this was at the low magnification. Then we focused on the epithelium part, because that we thought of like the lesional area, and we thought of like focusing it more and seeing it under high magnification. Then we saw that the epithelium is a non-keratinized epithelium of just one or two layer again, and it is having some dark hyperchromatic cuboidal flat cells, and below area was looking like some stellate reticulum cells. So we thought of like it might be just an aborted sort of enamel organ having bordered by the reduced enamel epithelium. Then we shifted our focus to the another tissue bit, which was showing the non-basophilic mucoid stroma and dark hyperchromatic cells. Here we can notice here the dark hyperchromatic spindle-shaped cells or stellate-shaped cells, angular cells we can notice, and we can also see small thin blood capillaries as well. So what we thought of like the mucoid stroma and thin angular dark hyperchromatic cells. So this could be the lesional area, and it was showing the picture of like what we can think of odontogenic myxoma, or it could be odontogenic fibroma, or simply it can be just a dental papilloma or dental follicle. Then like again, so when there is a such case is there, so we have to take a support of the literature as well to reach to the diagnosis. So clinical picture was not at all correlating what the histological picture was there. So when we saw the literature, so especially the differences between the two lesions, that is odontogenic myxoma and odontogenic fibroma. So clinically or radiologically, there is not much difference is there between these two lesions, except that odontogenic fibroma is multilocular radiolucency with scalloped border, and there is a presence of some calcification. So it shows the mixed radiolucency. But for the odontogenic myxoma, especially the origin of the cell was might be some authors have quoted that it could be arising from non-odontogenic origin, so myofibroblastic origin or fibroblastic histiocytic origin. And then when we saw the histological picture wise or the histological point of view, the differences. So first, the grossing feature. So grossing feature was for the odontic myxoma was like a white gelatinous soft tissue. So our case also we saw that the tissue was soft, jelly-like, and histopathologically, odontic myxoma shows again abundant mucoid stroma that contain rounded or angular spindle-shaped cells, and matrix is relatively avascular or may exhibit thin, delicate capillaries. And if there is a some variant like myxofibroma, then it should show the collagen fibers, which was not there much in our case. So and there is also sometimes occasionally presence of mast cells, although we did not see any presence of mast cells. So so moreover, the findings were going towards the feature of odontogenic myxoma. Then we saw some histological pictures also. We always do this so that we try to correlate what is our picture and whether it is looking similar to the images of what is there in the standard references. So when we saw this, the odontogenic fibroma, where there are two types, like especially a WHO type and a simple type. So in simple type, the stroma is a thick collagenous stroma, a dense collagenous stroma, having a thin, very small amount of cells. Whereas in case of WHO type, there is the stroma is little bit of what we can say myxoidal areas, but the epithelium component is having the strands or cords, which was not present sort of features in our case as well. So odontogenic myxoma. So presently we thought of like this may be the case of odontogenic myxoma. But then to call it as a odontogenic myxoma just based on the histological picture, so we have to have the support from the advanced investigations also, especially the immunohistochemical investigation. So again, we search the literature for how is the immunohistochemical profile of such lesion. So then we saw in our standard reference book that especially for rodent myxoma and other lesions, that Vimentin, it shows usually Vimentin positive and S100 negative. So that indicate that it is a myofibroblastic origin of the cells. Whereas when we see both Vimentin as well as S100 positive, so that indicate that it's of dental papilla origin, because Vimentin indicates the mesenchymal origin, whereas S100 indicate the neural crest cell involvement. And when the lesion shows only S100 positive, so it indicates that it's of neurofibroma or nerve sheath tumor. Whereas for the matrix, this is for the epithelial cells. Whereas for the matrix, usually in case of ordering myxoma, the matrix is rich in hyaluronic acid and chondroitin sulfate. So usually it shows the reaction positive for the Alcian blue stain, and typically it don't show any reaction with the past stain or positivity with the past stain. So, with this background, we did immunohistochemical investigation. We convinced the clinician, and fortunately, we could do the immunohistochemical investigation for this case. And this is the result for the Vimentin, where we saw that intense reaction in the area where there was a mucostroma and stellate or angular cells, and the typical epithelium is showing the negative reaction. Then when we focused this area at higher magnification, then we could see here that there is a intense positivity reaction for the epithelial cells for the Vimentin marker. So this indicates that it could be a myofibroblastic origin. So this was like main help for us to going for the diagnosis towards the myxoma. But then we have to see the other markers also. So typically, what we saw, the S100 was negative. So this was like helped us to rule out that this is not just a dental papilla or kind of just a dental follicle. And then, of course, the SMA, that is smooth muscle actin, was showing positivity only in the region of lining of the endothelial walls. Then about the special stains, then we saw past stain. It was like not much positivity for the stroma, and of course we did the Alcian blue also. So this is the photographs of Alcian blue stain, and for the Alcian blue stain, our lab had taken the positive control of intestinal mucosa, and like luckily we could see the reaction was positive, especially for our case here in the peripheral area. Although like it is a mild reaction, but yes, it is considered to be a positive reaction. So with this, like the immunohistochemical profile, like Vimentin positive, Yasan negative, then Alcian blue positive, PAS negative, and of course the histological picture helped us to reach to the diagnosis of odontogenic myxoma. So this was a sort of what we can say the protocol like we always follow, wherein the clinical picture and the histological picture, and take a support of the immunohistochemical investigation if it is needed. So odontogenic myxoma is actually defined by the WHO in 2022 as the benign mesenchymal tumor of odontogenic origin, and there is a central and peripheral variety. There is central variety of odomyxoma has high recurrence rate ranging from 10 to 43%, and presence of mast cells in odontogenic lesion may relate to their locally aggressive behavior. So here in our case, we could not see the histological point of view, the mast cells, but of course we could have done another special stain just to rule out there is no presence of mast cell, that is toluidine blue stain we should have done in this case. So this is also some learning lessons for us. There are some other markers also can be done, that is apart from Vimentin, that is BCL2 indicating the apoptotic pathway, especially positive for the epithelial component indicating the growth of the tumor, and Ki67, that is a protein marker which determines the aggressiveness of the lesion, and this CD117 someone can use for the mast cell marker. So these are the sort of all these immunohistochemical markers and pictures what we could think of. Now moving to the case number 4, that is an 18-year-old male patient having complaint of painless swelling on the upper right back tooth region since 6 months, and the radiograph, that is OPG, digital OPG, which was shared by a clinician. So we are always fortunate that most of our like clinicians share the information, especially the clinical point of view or the radiological point of view. So in that way, like what we can say, like we are very much fortunate here. Uh, so here in digital OPG, what we can see is like there is a dense mass, hard dense mass just distal to the 1/6 tooth, and there is one tooth, probably 1/8 tooth here impacted, and it has been displaced, and it has been displayed to such a high level that it is almost lying at the floor of the orbit, and there is also some cystic lesion around this tooth we can notice. So when we saw the 3D images for this picture on lateral view, the dense mass here we can see, and it is again lying at the distal region of the 1/6 tooth, extending up to the tuberosity and superiorly pushing the maxillary sinus wall here. And then the posterior anterior view of the 3D image, which was clearly showing the presence of impacted tooth here, and this is the dense mass. So one thing we can see here, that that's this dense mass and this tooth or the cystic lesion is very much closely approximating towards each other. So uh, this is the finding which we could notice here. Then when we received the tissue, first the hard mass, what we can see here, it was like just a dense mass and not resembling to any tooth-like structure. So, and then the soft tissue mass, the soft tissue specimen what we received is having again the tumor sort of a cystic lesion, sort of a lesion, having embedded the impacted tooth. So we separated this tissue from the embedded tooth, and then we did the processing and prepared the slide. So first we did the decalcification for this uh, hard mass, and then when we saw the histological picture at low magnification and high magnification, it was clearly showing that there is a regular arrangement of the dentin surrounding the pulp space. Here we can see surrounding the pulp space, and it was bordered by a very thin enamel matrix. So, since there is a regular arrangement of this hard tissue, so we can think of like this may be an compound odontome. So the hard mass was a sort of a compound odontome. Then the soft tissue mass was showing some different picture. So then, like it was showing that there's a cystic wall lined by proliferating epithelium here with dark hyperchromatic basal cells, and underlying fibrocollagenous stroma. So when we focused it on the little higher magnification for the epithelium, then we can see here the basal cells, especially the hyperchromatic nucleus having and palisading arrangement also, and the round to polygonal cells with clear cytoplasm. So this was the picture what we could notice in a very small area of the tissue bit, and the remaining tissue bit was not showing any other feature or like what we can say helping us to the diagnosis. So we thought of like a little bit of reorientation of such tissue, and the reorientation of the tissue had helped us to uh, think of some conclusive diagnosis. So after reorientation, the picture was more again clear for us that it was showing stratified squamous epithelium, and here we can see round to polygonal cells with eosinophilic cytoplasm having a vesiculated sort of basophilic nuclei. Here we can also notice that there is intercellular junctions are also present. So this stratified squamous sort of epithelium and was helping, and then we saw other areas also there. So it was showing the dystrophic calcification, areas of some dystrophic calcification. Here we can see in the just below the epithelium component, adjacent to the epithelium component. Then another tissue area was showing this sort of picture. Then we saw that this could be like round to polygonal cells with eosinophilic cytoplasm. It is filled with eosinophilic cytoplasm with pycnotic nucleus, and the cell outline here is very indistinct. So this could be like a sort of a ghost cells, what we thought of. So like there is a calcification is also present, then stratified squamous epithelium is present, presence of such ghost cells. So considering this histological picture, it was moreover going towards like what we call it as calcifying epithelial odontogenic cyst with a compound odontome. So, especially in this case, the cystic lesion was like first initially thought of like a dentigerous cyst or unicystic ameloblastoma, but it came out to be different. So one thing I hear here, I just want to say that like when we are doing PG or in a routine things, we always see some ideal pictures or textbook images. So we tend to have a thinking of like such structure should look like this only, but in reality it is not like that. So in reality we may have some varied picture also. So this is what is here we saw. So calcifying epithelial odontogenic cyst is also called as Gorlin cyst or cutaneous calcifying epithelioma of Malherbe. Typically, it is seen in bimodal age distribution, so that is in second decade and sixth decade. So present case where we saw the age of the individual was 18 years, falling in the second decade. And the common site here is anterior mandible crossing the midline sometime, but less usually in the maxilla, which was in our case. There is a displacement of the teeth. So here also we saw the displacement of the tooth, that is 1A tooth, then unilocular cystic lesion and associated with a complex odontome, but in our case it was kind of a compound odontome. The presence of ghost cell, of course, is not a characteristic feature, but if it is there, it helps in easy diagnosis. Then the origin of the COC lining is supposed to be arising from reduced enamel epithelium or remnants of odontogenic epithelium in the follicle. And there are two components for this lesion, that is cystic component and solid component. So cystic component has three varieties, like type 1A is supposed to be like a simple unicystic type. Then type 1B is like a odontome producing type. So in our case, we saw that there is odontome sort of lesion also approximating. So this could be like a type 1B lesion. And of course, type 1C is ameloblastoma proliferating type, which we did not see in the cystic wall any sort of ameloblastoma proliferations. And the solid component is supposed to be like a neoplasm dentinogenous ghost cell tumor. So, like in this case, the histological picture was like moreover clear, reaching to the conclusive diagnosis of COC with compound odontome. Now, moving to the case number 5, uh, I hope that audience is still active and listening to the or just saying, or if they have any doubt, they can ask in between also or at the end. So moving to the case number 5, so it is a again very interesting case, and it is a 53-year-old female patient complaining of recurring blister on the right side buccal mucosa in relation to the right side second molar. So here, what patient told that the vesicle was there and it had ruptured for 6 to 7 times in the same region. So this is one image what we can see, that there is a ruptured vesicle, and it has been ruptured for, or it has been recurred for several times, and like there is history of vesicle rupturing leaving behind the eroded mucosal surface. What one thing we noticed here is the referring dentist, the clinician, have recorded this case so beautifully, like the progression of the lesion, what we can see, the date wise. So all these photos were shared by the clinician. So we are really happy to see such records. So here we can see that this lesion has been recurred for several times. So initially, the clinician like thought of like this could be some ulcerative lesion. So he started with some topical steroid, and he also even tried few sessions of the laser therapy also. But then, despite of this treatment, the lesion kept on recurring again and again. So he referred that patient to us for the opinion of what can be done. So when we took the case history and all, we saw, and then we found that there is no other systemic findings or pertaining to the skin or involvement of any other organ or any areas. So then, considering the clinical picture that is recurring for so much of time, so we thought that it could be a vesiculobullous lesion, like maybe having a pemphigus or sort of a pemphigoid, that is mucous membrane pemphigoid, and maybe a bullous erosive lichen planus. So we advise the clinician to go ahead with the biopsy to confirm the diagnosis, as well as we also advised for advanced investigation, that is direct immunofluorescence test. So when we are going for the histological investigation as well as for the DIF for vesiculobullous lesion, so the biopsy site is very important. So when we are taking the biopsy, we should always take the area of the tissue from the perilesional site and not from the blister area or from the eroded area or ulcerative areas. Otherwise, it will give the false negative results in case of DIF also. So then, even for the histopathological picture also, so for investigation, we should have the adjacent area. We can also think of indirect immunofluorescence test, wherein we can just take 5 ml blood and we can go ahead with the indirect immunofluorescence test. So one more important thing is when we are planning for a DIF, we should have this Michael solution in hand, because as soon as the tissue is removed, we have to immerse the tissue in the solution. So then we saw the histopathological views of this tissue biopsy. So we see here that there is a parakeratinized stratified squamous epithelium, and it is clearly separated from the underlying connective tissue. So what we can see here is the clear subepithelial split. So the epithelium here and clear subepithelial split. So this is another bit of epithelium, but it was like a folded epithelium here on the main epithelium. So since there is a subepithelial split, the epithelium was separated. So when we saw under higher magnification, the epithelium was separated from the basement membrane zone. Okay. And here we can see the basal cells also, but there is no basal cell degeneration or any colloid bodies or civate bodies were not present. So this rules out that like there is no bullous lichen planus and also at all. So it may be having subepithelial split. So we thought of like maybe it is a pemphigoid sort of lesion. Then we waited for the DIF, but like unfortunately the DIF came to be negative. So, like as I said before, the site of the biopsy was is very important, but the biopsy was very much fine in this case because histological picture was very much clear. But then negative DIF, then how we should support the diagnosis? Like we were thinking of giving mucous membrane pemphigoid. Then we again searched the literature. Like, is there any other reason for DIF false negative results? Then surprisingly, we came across with one reference that was supporting that the DIF sometimes comes as a false negative when there especially the immunoreactant are weak, maybe because of the long-standing case or maybe because of the use of therapy or some laser applications as well. So in such cases, like what we can see is sometimes even though the biopsy is from the correct representative site, but the DI comes negative. So we should always have this information, that is especially the clinical information. So in our case, the clinician beforehand only had told that he had given the topical application for several time, and even he had used some sessions for the with the laser therapy also. So this helped us to say that that might be the reason the DIF have come negative. So one more important information we got from this literature that it is stating that especially the subepithelial split, that is especially the mucous membrane pemphigoid and other subepithelial autoimmune disease cannot be differentiated just based on histopathology or immunopathology. So such sort of lesion should be like considered as a subepithelial autoimmune diseases. So there are so many diseases are there in this category. I'm not going in detail of all those, but we should always think of like mucous membrane pemphigoid when there is no other systemic involvement, like involvement of the eyes or the skin and all. So this case we diagnosed finally as mucous membrane pemphigoid as a mild form because there is only oral mucosal involvement. So finally, lastly, like we are reaching to the last case, that is case number 6. So this is again related to the clinical point of view is very important, and it is also referred by one of the clinician here in our area, and the clinical information what we got is like the patient had come to us. So uh, it was a 24-year female patient complaining of pain and burning sensation, and there is a white patch since sort of like 5 years the patient was having, but patient was not bothered until there was areas of erosion with severe burning and difficulty in eating. So that time patient approached the doctor, and then that clinician had referred this patient to us. Then we took the case history, and interestingly, we found that although there is a bilateral lesion is there, so we first thought of like lichen planus, but the stress factor was not present. So again, on clinical examination, what we could notice here is like her several teeth were filled with large amalgam restoration. So here we can see like 3.6, 3.7, and 3.8, as well as this side, that is 4.6 tooth is filled with large amalgam restorations, and it is there since long duration, like around maybe for 10 years. So what she said. So this information, mm, we thought of like very useful information. Then, of course, we advised the biopsy because there was erosion. So what we saw on histological picture was there is a atrophic epithelium, and again there was no stratification. It's a flat epithelium, and it is like covered by orthokeratinized layer. There is a very prominent granular cell layer also we can see, and there is a band of inflammatory cell infiltration. So this was a sort of picture at 5x magnification. Then when we saw at little higher magnification, what we could notice here is there is dark brown pigments here lying just below the epithelium as well. So here also we can see there is dark brown pigment just lying below the epithelium, and the epithelium is atrophic with thinner epithelium, what we can see here, and the connective tissue area which was showing on the band of inflammatory cell infiltration was having a mixed population of the inflammatory cells. Like here we can see lot many plasma cells also. So along with the lymphocytes, there are a lot of plasma cells were also present. So when we saw the clinical picture, the history, and the histological picture, so we thought of like giving this as a diagnosis of oral lichenoid lesion. So based on this modified WHO criteria, so the lesion usually having a bilateral white striations of patch or clot sort of, and there is also areas of erosion, and it is associated with some drugs or dental material. So in our case, like we can relate it with the dental material, that is amalgam restoration. Then histopathological criteria was there: basal cell regeneration, severe bodies, atrophy of the epithelium, and band of mixed inflammatory cells. So we try to manage this patient at our center also, and we started with the treatment of like first we started with topical steroid application, then we switched over to systemic steroid because there is erosion. So and we gradually tapered it over a period of 2 months, and then we again continued with the topical steroid application, and we supplemented this treatment with antioxidants and multivitamins. And also one more important what we did is we asked the clinician to replace those all amalgam restoration, to see whether this correlation works here or not. So then, beautifully, like just after 2 months follow up, what we could notice here. So here you all can see that all the teeth which were filled with amalgam restoration were now being replaced by composite restoration, and we can see the change in the mucosa. So the mucosa as like moreover reaching to the normality. Of course, we can see the pigmentation here and little bit of whitish areas here. On the right side also we see the change in the mucosa. So this was 2 months follow up, and then 3 months follow up where like again moreover favorable towards normality. The patient had reduced all the burning sensation. Patient was very much happy with the state that she could eat, and there was like reduced burning sensation and all. So when we see the pre-treatment photograph and when we see the post-treatment photograph, like the lesion was like this, and then it turned out to be like this. So here, what I just want to say is like sometimes small things like replacement of dental material or replacement of such things might help for the management of the patient. So this was a sort of a case which we learned from the clinical point of view also, that whenever there is a large amalgam restoration, the patient tend to develop such lesion, and patient won't bother until there is a erosion or the burning sensation is there. So this was the sort of case again was referred to us by the clinician. So this is the end of the like case presentation, and at last, I just want to express my gratitude towards the POPMA governing body, and for giving me this opportunity to share our cases and experience with you all. And I thank all the attending members also for listening to this case presentations. Uh, and we are always open to discussion and learn from the experts. And also I would like to express the thanks to all the clinicians or the dentist who keeps referring their patients or believing in us, especially in this oral pathology practice. And last but not the least, I also thank Dr. Nidhi, who is my companion in oral pathology practice. So she is the one who keeps record of all these cases, and she maintains this very well. So I thank each and everyone here for attending this slides seminar. Thank you one and all.
Yes,
Thank you so much, sir. Outstanding cases, sir. And we have explained them in a very simplified way. The thoughts which should arise in the mind of pathologist, the rhythm of thoughts you have explained them in your presentation. So we can learn these things from your presentation. So I request from the audience if they have any questions.
yes, sir. It was indeed a wonderful presentation, sir, with the plethora of cases and a very good algorithm. So now it is open for discussion. Any points anybody would like to add or any doubts? They can unmute themselves and can ask those doubts. Okay. Dr. Swapnita, you can see any. mm,
Uh, Dr. Akhil Girdhar, he has mentioned Vandermeech criteria. in the chat box. Means, does he want sir to explain that?
Dr. Akhil, would you like to add something?
Okay, okay. He wanted to add about that criteria.
Okay, it was mentioned. Okay.
Okay, thank you. No questions in the chat box, sir.
Yes.
Yeah.
Uh, okay, then uh, Dr. Swapnita, I think you should present the certificate of appreciation to sir.
I thank Dr. Kiranzada sir for an insightful lecture. Thank you so much, sir.
Uh, Nidhi ma'am, I think sir, yeah, sir is there. You can unmute yourself, sir. Sir, you can unmute.
Yeah, there is some technical error was there, so I could not just rejoin back. Sorry for that inconvenience. Uh, if there is any question, I'm happy to answer, or if there is any doubt, if somebody has.
Sir, there are a lot of compliments for you.
Appreciation for you,
Yeah.
sir.
Okay, thank you. But I would have loved, like, if there is any question was also there. Yes. Yeah. Now I have just maybe my laptop has started back again.
Yeah, there is a question, Dr. Swapnita, by
Yeah.
Dr. Akhil.
Dr. Akhil Girdhar, it's a question from Dr. Akhil Girdhar. So he has asked you in case 5 why you went for pemphigoid and not for pemphigus. Sir, you're on mute.
Yeah. So, see, actually, pemphigus, like if you see clearly, there has to be a suprabasilar split first of all, and like here in our case, we saw that there is a subepithelial split. Means the epithelium was separated from the basement membrane zone, and there is a clear separation between the entire epithelium and the connective tissue. So that's why we thought of like going ahead with the pemphigoid rather than pemphigus. So again, of course, there are other modalities are also there, like DIF has to come positive, especially in the suprabasilar region. So that's why like we thought of like going ahead with the pemphigoid, not the pemphigus.
Um, so you mentioned that basal layer was attached. So
No, no.
he has asked the question.
Like, I had mentioned that the basal layer was separated. It was from the basement membrane zone. Like basement membrane zone means including the basal cells was separated from the underlying connective tissue. The basal cells in that epithelium were having intactness, means there was no degeneration or there was no colloid bodies or cavate bodies sort of. The epithelium was entirely separated. It was not having any contact with the underlying connective tissue.
So hope your query is answered, Dr. Akhil. Sir, one more question from Dr. Anjana K.
Yes.
She wants to ask, in case of radicular cyst, long-standing case, we can see a dormant epithelium like we see in case 1. Is it mandatory to be an arcading pattern?
Not necessary actually, because again in radicular cyst also we see the variation in the epithelium lining. So depending upon the like when there is a lesion was is infected, like a secondary infection, so we see there is epithelium proliferation. So whenever there is a lot of inflammatory cells in the connective tissue, in that case only we see the epithelium is proliferating. So thereby, like we can say that epithelium is proliferating, so we see arcading pattern there. So it depends upon the infection, the inflammatory response.
Okay, thank you, sir.
So, yeah, thank you so much, sir.
Yeah.
Now I present, I think there's some, okay, yeah, thank you. Now I present a token of appreciation to our moderator, Dr. Swapnita Patil, madam. Thank you so much, ma'am, for sparing your time and doing a wonderful moderation. I think it's a proud moment for your for a teacher and student duo like
Yes.
us.
Yeah,
Yes, yes. I just want to say here that, really, it is a great feeling that one of our student is moderating my session, and why I'm happy is because he is more interested in oral pathology.
yeah,
So, this is really nice to see Dr. Sapnita here, and good one actually.
yeah.
Happy
Thank you
to.
so much, Kiran sir. Thank you, Bhuvan sir, for giving me an opportunity to moderate the session.
Yes.
So,
Yeah, thank you so much, everyone.
yeah, now I request all the participants to put on their camera so that we can have a group photograph. Okay, I'll take one more photo. Yes. Okay. Yeah. Thank you.
Thank
So
you.
now we all will meet in 2026. So this was the last session for 2025, and the next sessions will have a plethora of different setup. We will have a slide seminar every month, and we will be coming up with a series of lectures for PG students, especially. It was a request by some of the PG students across India, so that will be there. And the next session will be by Dr. Priya NS ma'am in January, and I'll keep everyone posted about the update for the upcoming study club of POPMA. So till then, stay healthy, stay fine, and enjoy oral pathology. Uh, a very happy New Year 2026, and stay blessed. So bye everyone, and thank you
Bye.
so much. Thank you so much, Kiran sir. Thank you
Thank
so
you.
much.
Thank you, sir. Thank you.
Okay. See.
Yes. It is because of you actually, I became what we can say moreover leaning towards presenting the cases and all. Actually, even though like we have so many cases, but we never thought of like presenting the cases actually.
Yes, yes, right,
So,
sir. So
really
this is the
appreciate it.
main intention behind, because we learn with all our cases.
Yes,
So
yes.
if everyone shares, so this is just an informal way of sharing. It is not a
Yes,
what should I say, a formal platform, because as practitioners we all should discuss about the what all challenges we face in the practice
yes,
or pertaining to the
yes.
histopathology, and we all can share our experience. That is the only.
Yes, of course, actually.
So
And even just one thing like here, we have even shared this link with the clinicians also, like those
yeah,
who have shared their cases to us, so that they will also come to know that, yes, we are acknowledging them, and
yes,
we are giving due importance because they are the one who are sending their patients or cases to us. So this
right,
is
sir.
what we did in our case today.
Yes, very right, sir. no, by this we all will have a multidisciplinary collaboration, and
Yes,
yes, we all are. It's a teamwork with
yes, sir.
clinicians as well as oral pathologists. So it's always better and good and ethical also to acknowledge their
Yes,
efforts which they have done. So
yes, yes. Thank you, sir.
you're welcome, sir, and thank you so much once again. And see you in the
Yes, sir.
next
Tomorrow,
session. Yeah, in
tomorrow
January.
we have AGM, na?
Yes,
Mm-hmm.
yes. Tomorrow we have AGM from 3 p.m. onwards, and I request all the POPMA members who are present here should attend that and give their feedbacks or suggestions, whatever they have in their mind, and should see that what all activities POPMA has done, what all we are doing, what all our legal framework and the different activities, not only pertaining to the academia, but the other administrative activities. So,
Yes,
because the future lies with the other members, and
yes,
it is always because the association is made by members, so everyone should be aware of that.
yes, yes,
So
of
we are in
course.
the way of like planning for that. So
Mm-hmm.
see you for tomorrow, sir.
Yes, sir.
Okay,
Yes,
sir.
sir.
Okay,
Yeah,
thank you
yeah,
so much.
yeah. Okay.